First case is from Jayadeva Institute.
Good afternoon, respected teachers. Myself, Dr. Gopi Daparanji. I am presenting a case from Sri Jayadeva Institute of Cardiovascular Sciences, Bengaluru. This is a case of 20-year-old male patient who is a resident of Salem, Tamil Nadu, currently working as a tractor cleaner. Is coming from a low socioeconomic status and studied up to 10th standard. And the history is given by the patient and his father, and that is reliable. He presented with chief complaints of fatigue for the last 7 years and breathlessness for the last 7 years, which have worsened over the past 2 months. And additional symptoms like pedal edema since 2 months and abdominal distension since 1.5 months. As patient had significant past history, I would like to start with the past history. As history given by the father, he had recurrent episodes of respiratory tract infections associated with cough with expectoration and occasionally associated with fever and chest retractions and breathing difficulty, which are requiring inhalational and injectable treatment. Started at the age of 6 months. At that age, he used to have around 5 to 6 episodes per year till 3 years of age. After that, the episodes were reduced and he used to have 1 to 2 episodes per year till the age of 10 to 12 years. And there is a history of feeding difficulty. The baby used to drink milk for 2 to 3 minutes and then used to starve for few minutes, and which is associated with the sweating over the forehead and pounding of the chest noticed by the mother. And there is history of failure to thrive as baby did not gain weight as per his peers. And with these complaints, with the LRTA, at the age of 3 years, he was diagnosed to have heart disease. He was told that he had a hole in the heart by the pediatrician who examined him, and was advised to consult a cardiologist, but later they were last to follow up because of financial constraints. Coming to chief complaint, he had history of easy fatigability for the last 7 years, which was initially on climbing 2 flights of stairs and uphill or walking for about 1 to 1.5 kilometers, suggestive of NICA class 2. For the last 2 months, he noticed to have breathlessness even on walking about the house and bathing and routine activities, which is increased to NIHA class 3 and relieved by rest. Along with easy fatigability, a patient is also noticed breathlessness for the last 7 years. It started along with the fatigue and initially started as NIHA class 2, now progressed to NIHA class 3 in last 2 months. There is no history of paroxysmal nocturnal dyspnea, no history of arrhythmia. And with this complaint, the patient currently admitted in a hospital and is on treatment. Now, this breathlessness and fatigue improved to NIHA class 2. And breathlessness is not associated with any cough with expectoration, fever, or bluish discoloration. Along with fatigue and breathlessness, patient also noted swelling of the both lower limbs since 2 months, initially noted in the ankles and which is gradually progressed to involve both thighs in 1 week. After that, he noted the abdominal distension, which is of generalized in nature, and there is no history of abdominal pain. Both these complaints are now relieved with the treatment. One month back, with similar complaints, he was admitted in nearby hospital for 1 week and was discharged on oral medications. After that medication, he was stable for 1 week, following which he noticed that symptoms have worsened and developed again swelling of both lower limbs and followed by abdominal distension. There is no history suggestive of any chest pain or pre-syncope or syncope. There is no history of palpitations. There is no history of bluish discoloration of skin and mucous membranes. There is no history suggestive of cyanotic spells or no history of hemoptysis. There is no history of headache or limb weakness, no history of sore throat with joint pains, no history of prolonged fever or hematuria. Coming to birth and developmental history, he born out of non-consanguineous marriage as full term with normal vaginal delivery, which was conducted by local ASHA worker at home. And baby appeared normal at that time and cried immediately after birth and attained milestone as per age. Coming to maternal history, there is no history of diabetes, hypertension during the pregnancy. There is no history of any drug intake during pregnancy. There is no history of fever with skin rash or other infections. He had 2 elder siblings. They attained milestones as per age and both are asymptomatic. There is no history of any similar illness in the family members. And he takes mixed days, sleep is normal, and he knows to have reduced appetite and increased urine output since 2 months. Bowel habits are normal. Coming to summary, a 20-year-old male who had a history of recurrent LRTA at the age of 6 months and diagnosed to have heart disease at the age of 3 years, static for 10 years, And at the age of 13 years, he noticed fatigue and dyspnea of class 2. Now sudden deterioration to class 3 over the last 2 months with additional symptoms of pedal edema and ascites. With this background, my differentials are shunt lesion with initially increased pulmonary blood flow, which has now become reduced pulmonary blood flow. In that shunt lesions are most probably these ventricular septal.
Sorry, before you got on to that, can you explain the history as to what, if you can go back to the previous slide? Yes. So what contributed to the LRTI? What contributed to the diagnosis, and what is the current status? Can you explain hemodynamically what's happening?
As he developed recurrent LRTI at the age of 6 months, which is suggestive of there is increased pulmonary blood flow, sir.
So 6 months, which condition produces increased pulmonary blood flow at 6 months? What is the classical age at which increased pulmonary blood flow happens in patients with left to right shunts?
Yes, sir. Usually it develops at the age of 6 to 10 weeks, sir, in term infants. If it is preterm, then 3 to 6 weeks.
Yes. So 6 months, isn't it a little late?
But actually, this is a very long back history, sir. Maybe they couldn't able to recall the history. At the age of 6 months, they visited the hospital. That only they could able to recall.
But you have told the history that patient has a history suggestive of heart failure from at the time of birth or after the birth.
No, sir. No, sir.
You have told he has a feeding difficulty, failure to thrive. So
That
feeding
is also
difficulty with a breast milk will only occur within 6 months. It will not occur at 3 years. In your
not
history,
at
you have very
years,
well
sir.
described it.
At the age of 6 months only, they have started noticing. I mean, that time only they said, but maybe before that also he had, but they were not able to recollect those histories.
Yeah, that is okay. That may be a soft thing in the history, but classically, you must know what is the age at which these symptoms of recurrent respiratory infections and feeding difficulties and all those things happen in these shunt lesions.
Yes, sir. Yes, sir. Usually
earlier, little earlier. It happens
Yes,
at about 6 weeks to 12 weeks.
Yes, sir.
Okay.
What is the suggestion? Why are you saying there are recurrent LRTI? What is the definition of recurrent LRTI in this patient?
There is IAP definition is there, ma. Two significant severe LRTI in 1 year, or 3 episodes in any time period, or 6 URTI in any time frame.
So how many has he had?
Initially, he said per year he used to have 5 to 6 episodes till the age of 3 years. After that, episodes reduced to 1 to 2 episodes per year.
So which is the disease which will give you continued LRTI till 10 years of age? Because you said he continued with LRTIs till 10 years of age. Am I right?
Yes, ma'am. Yes, ma'am.
So which condition are you really thinking of, which goes on till 10 years with recurrent LRTIs?
ASD, ma'am.
ASD gives you LRTIs, recurrent LRTIs?
Does it give LRTI at all at 3 months and 6 months?
After 3 months, once the RV regresses, the shunt might increase. Because
and why does it continue to give till 10 years of age?
Usually we'll have in PD and VSD, ma'am.
So what is the conventional history in PD and VSD? I agree that they do have recurrent LRTIs in infancy. They also have history suggestive of heart failure, but does it go till 10 years of age? That's the question.
Actually, the shunt starts reverses by 2 years, ma'am, less than 2 years. So
reversal.
She said 10 years. I heard 10 years.
Yes.
Although
Can you show the previous slide? I think she didn't say 10 years.
Yes, ma'am. Yes, ma'am.
Yes.
You said
She
10
did.
years. Okay.
Yeah. I heard it.
The episodes, ma'am. Initially, he used to have 5 to 6 episodes. After that, he used to have 1 to 2 episodes only.
So why would anybody have 1 to 2 episodes? First of all, do you think those 1 to 2 episodes are like happening in any normal child, or you are giving some importance to that 1 to 2 episode?
Can be non-significant, ma'am, in this scenario.
So see, that is why your history telling is important. If you tell us that he used to have 3 to 4 episodes till 3 years, then it became 2 episodes, then we presume it is the same disease that is carrying on, and it is still going to bother, it is still bothering him till 10 years of age. Now you are saying till 3 years it was okay, but beyond that it has become normal. So there's a big difference between the two. Now,
Yes.
which is a lesion which gives you LRTI till 3 years of age?
VSD or PDM usually gives.
Why do they give till 3 years, and why not before, and why not after?
Ma'am, up to the age of probably 6 to 8 weeks, that persistence of that neonatal pulmonary hypertension will be there. So when that regresses, the
So what happens at 3 years? No, my question is what happens at 3 years? Why do
PVOD
they
starts
stop?
developing.
PVOD.
Yes.
So you are saying that PVOD starts developing at 3 years of age.
At the age, yes, ma'am.
And then the features of recurrent LRTIs go away.
Comes down, yes, ma'am. Once the blood flow to the pulmonary circulation decreases because of the increased PVOD, pulmonary vascular resistance, then at that time the patient start showing that no episodes of LRT at that point.
Okay. So the improvement has happened because of PVOD.
Yes.
Yes.
That's what you are saying.
Yeah, yes.
Okay. Okay. Usually 3 years is a little late. That starts beyond first
Right.
or second year itself. But
Yes.
anyway, as you said, your history may not be correct because the parents may not have been able to give you a proper history. But generally 3 years is a little late for that. It usually starts by about 1 to 2 years of age, and therefore the recurrent LRTIs tend to go away beyond infancy. And definitely not 10 years. Definitely not 10 years.
Yes.
You need to know that. Only then you will interpret the history accordingly.
Yes.
Yes.
Okay.
So now
Okay,
what has
go
happened
ahead.
now?
Yeah. What else has happened?
happened now in the last 5-7 years, whatever you have said, and the last 1 year or the last part? What has happened now?
Now, at the age of 13 years, he noticed to have NIHA class 2 fatigue and dyspnea, sir. This breathlessness is not associated with any PND or orthopnea.
So what is
Yeah, that is
No,
okay. We
what
understand
is-
that.
yeah.
What is your interpretation?
Yes,
is
tell us
happening?
your
You see,
interpretation.
He's
We
developing
understand
RV. Yes, ma'am.
Just a
RV
sec.
dysfunction.
Just a sec. We understand patient has a shunt lesion by your history. Now tell us what is happening.
Pulmonary
And based on
hypertension.
that, we will come to a suspected diagnosis or what you will think on that.
Yes.
So what is happening?
Patient is developing significant pulmonary hypertension and leading to RV dysfunction, sir.
So are you saying that in a VSD or a PDA at 13 years, Eisenmenger's develop RV dysfunction?
With the sin.
What is the natural history of an Eisenmenger VSD or PDA? When do they
Usually,
develop RV dysfunction?
Eisenmengerization usually in VSD will see at the age of 22
No,
years.
the question is different.
No, the question is different.
RV dysfunction, because you mentioned that
Yes.
RV dysfunction. So we are just asking you at what age is in an Eisenmenger VSD or PDA RV dysfunction develops, because you are claiming it is happening at 13 years in this child.
Usually at the third decade. No?
So you have to think of something else rather than bringing RV dysfunction.
Okay. Significant pulmonary hypertension.
Pulmonary
No, the
hypertension
shunt
was
is
always
common.
there.
Ma'am, the
Pulmonary
shunt is reversed,
hypertension
ma'am.
was there from the very beginning. You must differentiate between pulmonary hypertension and pulmonary vascular obstructive disease.
Yes, ma'am.
PAH was there on day one, right? As per your history. Only the shunt has now started to become reversed because of PVOD. Because of PVOD. Now the question is, the child remained all right till 13 years of age and then started to develop symptoms again, right?
Yes, ma'am.
You need to tell us why, because you are denying any history of cyanosis.
Yes, ma'am.
What are the components of pulmonary hypertension? As Madam has said, she said that to differentiate between PVOD, pulmonary vascular disease, and PAH. So, what are the components of pulmonary arterial hypertension?
Sir, like if in case of hyperkinetic pulmonary hypertension, patient might give an history of palpitations. Sir. But
No. What is the pathology? Pathophysiology, I am asking.
Sir, in case of pulmonary hypertension, the resistance depends upon the flow. Sorry, the pressure depends upon the flow as well as the resistance. So increased flow can also raise the pressure. For example, increased pulmonary blood flow alone. Other way, around in case of pulmonary occlusive disease, where the obstruction can raise the pressure. So this is the difference.
Is there a component of spasm? Is there a component of vasoreactivity? Is there a component of proliferative pulmonary arterial changes. All these are there, or what all happen in this particular time?
Sir, it has around 6 stages of development of pulmonary arterial hypertension because of PVOD. The first 3 stages are reversible, and that is probably because of increased vasospasm and the reactivity. But once it comes to stage 4 to stage 6, it's due to the development of the smooth muscle hypertrophy and the development of fibrosis that prevents the reactive form of the disease, and it becomes permanent, sir.
No, but all these shunt lesions at 13 years, will they have that grade 4 to 6 changes?
Yeah, that is what. Yeah.
You see. So that is that. So whatever it is, the patient is now again getting symptomatic. We understand.
Yes, sir.
Now, then you say that the symptoms of fatigue dyspnea are there and they have now worsened and over time, and of late he also has pedal edema and ascites.
Yes.
Now, explain me this pedal edema and ascites.
So for this, like
What is the hemodynamic status? You should say that. What is happening?
Now the RV dysfunction has set in, sir. The development of pedal edema and ascites.
No. I don't want RV. I want clinical diagnosis. What is the clinical setting now? The patient is in heart failure?
Yes.
Eisenmenger with heart
sir,
failure,
yes,
sir. Yes, sir.
So heart failure. Tell me which Eisenmenger will go into heart failure. That is the point.
Sir,
Will VSD or
yes,
PDA, will a post-tricuspid shunt like VSD or PDA go into heart failure at 20 years of age?
Sir, it's
clinical heart failure. RV dysfunction, whatever dysfunction, that's secondary thing. But he is in clinical heart failure according by history.
Yes.
So you think this is natural that a patient who is born with VSD will go into heart failure at 20 years of age?
Sir, it's a little early for
it is early.
VSD.
Just hold on. That means you are trying to say he will go into heart failure at 30 years of age? The question is, there is a post-tricuspid shunt. The recurrent LRTIs at 3 months and 6 months, what we were talking, they happen in post-tricuspid shunts more.
Yes.
Right? So you are suspecting a post-tricuspid shunt?
Yes, sir.
So do I believe that post-tricuspid shunt will go into heart failure?
They will decongest into the LV.
LV,
so,
what has LV got to do with it?
No, sir. The shunt will decongest into LV. So the development of the RV failure will be usually uncommon in the post-tricuspid.
Yes. What is the heart size? It is in VSDs, PDAs with Eisenmengers and severe PAH. It is normal. They will not go into heart failure.
Yes.
Which one will go into heart failure?
The pre-tricuspid. ASD.
Pre-tricuspid will go.
Yes.
Or what else? Which amongst the post-tricuspid will go? Which amongst the post-tricuspid will go?
PDS. PDS, because the patient can develop a PR.
No, PR is same. The pressure in the PR will be at a systemic pressure. That's all. It will not be suprasystemic. You have to think of situations where you might get a suprasystemic pressure in spite of just a VSD or PDA. So think of those situations. You see, there could be situations, you see. Can you name some or think of something?
If the patient develops any associated pulmonary arterial disease, like in the presence of pulmonary embolism or development of fetus.
If somehow the VSD starts getting, gets small, there's something which is obstructing the VSD, or there is a restrictive VSD, you know, the VSD is slightly restrictive, or there is something that is happening which is closing the VSD.
Yes,
and the pressure is getting suprasystemic. So some things like that, not very common.
Yes,
okay, I think if it's okay, should we move forward to the examination?
I think one more possibility that they have to think about, the reason for early failure is the AV valve regurgitation.
Yes.
Because conventional VSDs and PDAs don't tend to go into failure. You need to find, if you're making a diagnosis of VSD PDA, then you need to bring in an additional factor to precipitate heart failure. That could be an arrhythmia. That could be an AV valve regurgitation. So these are two things. And if you think of AV valve regurgitation, you have to think about AV septal defect.
Endocardial. Yes.
My question is one, it can only be a left to right shunt or some more complex congenital heart disease, which has a minimal cyanosis and which has missed.
Yeah, I think they should think, especially if he's going into failure and more symptomatic early, they can think of some admixture lesions like DORV with large flow, which is producing PH.
So if it is so, like by 7 to 8 years, like all the patient will develop cyanosis. Like till the age of like 13, without cyanosis is taking a diagnosis of
So
complex.
by history, there is no cyanosis according to you.
Yes, sir.
So maybe on examination, is it possible history is no cyanosis, but on examination you find cyanosis? Is it possible?
Yes.
Yes, yes.
Yeah. So we cannot be very foolproof on that.
I would agree with them because cyanosis, if it is significant, it should have been picked up by examination. By history. Sorry. I meant by history. So in an admixture lesion or the complex lesion Dr. Rakesh Yadav was referring to, the statement that they have to give for defending is right, that generally in those conditions, cyanosis will be too obvious to be missed by history also.
Yeah.
Okay.
But otherwise, in a regular VSD PDA, there may be light cyanosis, which you will only detect on examination. History-wise, the patient will not give you that there is a history of blueness. Blueness largely patients give when there is decreased flow situation.
And second important thing, sir, they have told that there's no history of cyanosis at all. So why you are making history of Eisenmenger? Eisenmenger going in heart failure without any history of cyanosis, it's very common, uncommon, or rare.
Eisenmenger usually cyanosis will be mild compared to other cyanotic congenital heart diseases.
Yes. I think cyanosis will be mild, so you may miss it. But the patient may not detect it, but you will detect it if you are doing the examination.
Yes, sir.
Okay.
I think we should proceed to examination. 20 minutes fast.
Yes. Dr. Shantanu, you must tell us when to move forward.
You have already taken 20 minutes on interrogating the history. So carry on.
Okay, Dr. Guha, we are the new examiner.
So first examination will always be very stringent, I know.
Right. We'll get tired very soon. So let's go ahead.
Hello. Okay, examination.
Coming to general physical examination, patient is conscious, oriented to time, place, and person, lying comfortably in bed, and height is 150 centimeters, weight is 37 kg, BMI is 16.4 kg per meter square, and there is no history of there is no pallor, no cyanosis, no pedal edema, and mild icterus is present. Grade 2 clubbing noted in bilateral lower limbs.
No, icterus is present.
Mild icterus, sir.
No, what do you mean by mild? Icterus is icterus. That means
Yes,
what would be the bilirubin if you are saying icterus is present?
More than 3, sir.
More than 3. Clinically detectable more than 3.
I think it's more than 2, certainly.
2, yes, sir. Yes, sir. 2.
Okay. Go ahead.
Coming to vital data, temperature is normal. Pulse is 1 or 2 beats per minute, regular, normal volume, no special character, no radioradial or radiofemoral delay. All peripheral pulses well felt. BP is 100/70 in both upper limbs and 110 in both lower limbs. Respiratory rate is 24 breaths per minute, abdominothoracic type of respiration. There is no use of any accessory muscles. And saturation noted to be 95% on room air at rest in both the upper limbs and 83% on room air in both the lower limbs. This is the image showing the grade 2 clubbing in both lower limbs compared to upper limbs. And this is the differential cyanosis showing upper limb saturation is of 95%. With lower limb saturation is of 83%.
Do you think this is the way to diagnose differential cyanosis? How do you diagnose differential cyanosis?
Base, I mean, lower limbs will have cyanosis, ma'am, and upper limbs will be.
Does the patient have a paint on the
Yes,
nails?
ma'am. Yes, nails.
So how will you detect cyanosis, right? When there is nail polish or nail paint there? So you can't.
Yeah, that's why in general,
And then I don't know, because you have to.
right?
I mean, I take strong objection to 2 pulse oximetry being used. See,
Okay.
tomorrow you are going to say that I had only 1 pulse oximeter, so I did not decide. I could not decide about differential cyanosis. Please don't do that. Don't be so technology driven. You
No,
have to
ma'am,
look at the patient. You have to look at the patient's fingers. You can put the fingers and toes together like you've done now,
Yeah, that
but
is how
not
you
with an
do it.
not with an oximeter. Please
And
don't
And if you
use
are,
2
and if you
oximeters.
are, no, if you are using oximeters, then why do you want to put it like this? Then you just do the oximetry and you know the oximeter is telling you this was saturation.
just to
Correct.
show demonstration, we have
Nahin,
put, sir,
nahin,
this
nahin.
in. Okay, sir. Okay. Okay.
I
Firstly,
mean,
the
if I am
nail-
the examiner, I'll cut marks to using 2 oximeter. I think that's atrocious. Why should you use 2 oximeters?
Ma'am, I think they are thinking that cyanosis is very variable. Within a minute, the cyanosis reading will change. Or they are
Is it
thinking like this.
possible?
That's why they have used the same oximeter, 2 oximeters. Is it going to change?
Is it going to change?
No,
No. Why? Then is there an importance?
No.
What if you had 1 oximeter and
Yes.
you take the saturation of the
Both.
toe and you take it of the finger
At different time. They will say at different time.
Take it one after the other or different time. What difference will it make? Tell me,
No,
when
sir,
will it make a difference? When will it make a difference, if at all? Tell me
When
one
reference-
clinical setting it will make a difference. Okay. Tell me one clinical setting, you take it like this, and one clinical setting or a physiological setting, it will be different.
When there is a vasoconstriction because of the
No. Within a minute, will change.
When will it change? When a person is
post exercise, it
if
might.
a person is exercising or then the values may change.
Yes.
Okay. But
Who
anyhow,
described differential cyanosis?
Yes, ma'am.
Who described it first? Where did you read about it first? Sorry.
Is it from Paul Wood?
So did Paul Wood use oximeter?
Yes, that is a question. It's a clinical sign or it is a investigational sign?
It is a clinical.
Clinicals.
Eventually, if it's not detected by this, they've asked to place the warm water, dipped into warm water all limbs and then compare.
I think you people are trying to make it very complicated. It's a very simple sign that you are supposed to see on physical examination. So oximetry comes much later. First, it has to be clinical. Like you said, clubbing. You said clubbing same in the upper and the lower limb, right? Similarly, you need to say whether there's uniform cyanosis or there is differential cyanosis. As a physical finding, there is no question of bringing in oximetry there. Oximetry will only tell you how much it is. It's not going to tell you if it is cyanosis or not. It will only tell you how much is the saturation more accurately than your eyes can tell you. So don't make everything so complicated. It's a very simple sign. That's it.
Okay.
So the clubbing is also differential or clubbing is uniform?
Lower limbs.
Lower limbs, there's a grade 2 clubbing.
So that is also differential. Means upper limb there is no clubbing.
No, sir.
Okay. Shall I move forward?
But you did not say that in your examination.
We told, ma'am.
I think they said somewhere.
Grade 2 clubbing noted in
Yes, sir,
violence.
ma'am.
Grade 2 clubbing in lower limb.
They said only upper limb, grade 2 clubbing in the upper limbs.
Okay.
No, lower limb.
Lower limb, sorry. Lower limbs only they said.
Right,
Yeah,
right.
yeah, that's what.
So that it immediately tells you about differential cyanosis, no? Immediately.
Yes.
Okay.
So what will you do if there is the cyanosis is not obvious clinically? What all things can you do?
One is
Exertion. You can exert the patient and seize it.
This patient has morphoid feature because fingers and nails indirectly telling.
Her height is 150 centimeters.
height,
How much?
150
150,
centimeters.
sir.
What is the arm span?
Around 152, sir.
Not around. has to be a value.
No, have you taken it? Because
Yes, sir. Yes, sir.
you
Taken,
have
sir.
to be
152.
clear. What
150.
is the criteria of Marfanoid habitus?
Our arm span will be more than
When the
More
height
than-
by more than 3
I'm
centimeters, 3 to 5 centimeters.
I think it's more than 5 centimeters, if
mm.
I'm not wrong. Yeah. Okay. Chaliye. What else? So now JVP is raised.
yes, a JVP raised 7 centimeter above the sternal angle in 45-degree position with
What is
prominent
the mean RA pressure?
7 plus
What is the mean RA pressure?
13,
Huh?
13 centimeters of water. Sir.
13. Why 13? Why not 12? Why not 14?
Sorry, 7 plus 5, sir. Usually RA is 5 centimeter below the sternal angle. Usually we'll take measurement from the sternal angle.
No, so 7 centimeters at 45 degrees makes it mean RA pressure of 7 and 5, 12.
12.
Does it make it 12?
12
Yes.
centimeters.
No, it doesn't.
12 millimeter of
There is-
mercury, it will be a 12 millimeter.
नहीं, water, जो भी है, वो
No,
centimeter of water, millimeter, centimeter of water. But the point is 7 and 5 will not make it 12. Tell me why. Whatever you have written, according to what you have written, I ask you, what is the mean RA pressure? Think about it and answer again. Will it be more than 12, less than 12? It will not be 12, I can assure you. You see what you have written. Read it again. JVP raised.
JVP raised 7 centimeter above the sternal angle in 45-degree position.
In 45-degree position with prominent A and B there.
But
Okay.
whether it is supine or vertical or 45-degree position, there won't be much change in right atrial position.
There is no scope of much. 7 centimeter is the vertical height or 7 centimeter is the column? What did you say? Because at 45 degrees, you can have a 7 centimeter column or you can have a 7 centimeter vertical height.
Vertical height.
I think when you say JVP, it has to be a vertical height.
Yes.
What is the definition? What is the definition of JVP if you say?
If it is vertical height, then it is okay.
It is
No,
measured
that's
as vertical height only. It is measured as vertical height only.
Yeah, because if it is vertical height, then it is 12. But if it is only in 45 degrees that you're getting a 7 centimeter column, that is going up 7 centimeters.
No. I think when you say
If it is
JVP,
vertical height, it's fine. If it's
no, there is
vertical
no
height, it's
other.
fine.
There is no other way. It has to be
There is
vertical height.
sometimes at 45
No,
degrees, you see.
That is not JVP. Then it is not
I know,
called
but there
JVP.
are some, no, this I am just saying because some people, some students I have seen that at 45 degrees, you see it little higher. They say there is a 2 centimeter column that I am seeing. But when you make it vertical, it is not there. So the JVP actually is not raised that time.
No, what I'm saying is even if you are measuring at 45, you're actually measuring vertical distance only. So it doesn't matter.
You have to measure
Doesn't
vertical
matter.
only.
Yes,
I
there
don't
is no
know,
other
sir.
way.
This has to be
There is-
reconfirmed that he is measuring vertical.
No,
Did
there
you
is no
measure
other way.
vertical? That's the only way, correct. So, but I have observed some people are not measuring vertical. They are only describing the column length. So then it becomes,
No, that is wrong.
that is wrong. Okay, go ahead.
This is the video showing a patient lying at 45-degree position and showing prominent JVP. JVP elevated with prominent A and B waves. Sir.
What about descents?
Y descent is prominent, ma'am.
Yeah, which is the I can't make out which is the foot end, which is the it is vertical neck or kya hai? I can't make that.
So this is foot end, sir.
Huh?
This is the base of neck and the JVP is
Acha.
extended up to angle of the mandibles.
Okay. This is the neck. All right, now I see. Okay.
So go ahead.
Right, go ahead.
Coming to serious examination and inspection palpation combined together, chest is asymmetrical with precardial bulge And visible pulsations are present in left second intercostal space, left and right parasternal area and epigastric region. And apex beat is palpable in the left fifth intercostal space and midclavicular line, which is of diffuse in nature, suggestive of RV type of effects. And palpable P2 in left second intercostal space. Grade 3 parasternal heave is present. There are no thrills or no scars.
Okay.
This is the precardial video showing the precardial activity of the patient taken from the foot end of bed, which is showing precardial bulging with prominent pulsations in the right and left parasternal region with epigastric pulsations.
Okay.
In percussion, left heart border in line with the apex, and right heart border corresponds to the right sternal border, and liver dullness noted in the right fifth intercostal space, and tympanic noted in left upper quadrant. Left second intercostal space dullness is present. An auscultation, S1 is normal. Wide fixed split with loud P2 component is there, and RB-S3 is present. There is no S4, and a soft blowing pansystolic murmur of grade 3/6 heard in left parasternal region and fifth intercostal space, best heard with the diaphragm of the stethoscope, which increases with inspiration. There are no any extra sounds. Coming to other system examination, per abdomen is soft, liver is palpable 3 cm below the right costal margin with soft in consistency with rounder borders, and mild tenderness is present, which is not pulsatile, and liver span is about 14 centimeters. There is no splenomegaly, no fluid noted, and respiratory system and CNS examinations are normal.
So you think this liver will be non-pulsatile? Palpable with the type of JVP and the precordium that you showed, you think he will have a non-pulsatile liver?
Partially treated.
Because you showed a very, we could see very well the V wave and A wave, both whatever V wave certainly. Usually it should be pulsatile also, if it is so. Go ahead. Okay.
Diagnosis.
Final diagnosis, situs salitus with livocardia and acytonic congenital heart disease, postductal PDA with Eisenmengerization, with severe TR and RV dysfunction, currently in NIHA class 2, sinus rhythm, no features of infective endocarditis, and he is undernourished.
Tell us what are your findings which are against your diagnosis? Which are not fitting with your diagnosis.
One is severe TR, ma'am, because it is more common with the ASD Eisenmenger rather than PDA.
Severe TR. What else? What else?
Wide pitch splitting.
Yes. What kind of split you get in PDA?
Usually narrow.
Variable split.
So normal or narrow
Split.
split. So how do you
You see,
explain these two aberrations in this patient?
now, these two findings, or rather the first finding of that severe TR, JVP, the pounding chest, I could literally see this patient must be having a 3/3 heave, and the enlarged liver, and even icterus. You said icterus,
Yes,
which
sir.
again shows that the patient is in gross heart failure. Did you say heart failure? You think this patient will be an NYHA class 2? I don't agree at all.
Now he is in
Now, just a
NYHA
sec.
class.
Just a sec. The way you presented, and I agree with your findings. Your findings are good, but you have to understand the hemodynamics. This patient is in gross congestive heart failure. He has pedal edema also, you said, isn't it?
Now reduced with treatments.
Reduce, it will not become normal. Yeah, the heart failure will still be there.
So you see that video, no, the patient. Yeah, you see the video. The patient was tachypneic. Patient was tachypneic. Yeah, the patient was tachypneic, and I don't think it is definitely class 2.
You literally, because you showed us the patient, so that we understand what the patient is. This patient is in gross heart failure. You showed us a JVP, such a bounding JVP. There is no way that you can't. You have to write this patient is in heart failure.
You have not mentioned. Yeah, the heart failure thing is not mentioned in the diagnosis.
I somehow, I agree the findings of TR should not be there, S2 split, fixed or whatever. But grossly, PDA going into heart failure, your diagnosis is PDA. You
Yes.
have to tell us why PDA has gone into, because I don't expect the PDA patient to go into heart failure and at least at this 20 years of age. I'm sure the patient has something else in addition.
And second, why he has a fixed and wide splitting? You
ठीक
also
है, that's a soft thing. अब उनको wide fix लग रही है, किसी को
and
narrow
fix.
मिल जाएगी.
No, no,
मगर
wide
जो
and fix.
picture में
Wide and
दिखा रहे
fix.
हैं, वो तो gross है ना. That is very gross. What we have seen is very gross. So there are some hard findings in a patient. There are some soft findings. S2 split, okay, it's an interpretation game. It could be soft, no problem. But the heart failure is a gross heart failure. Severe TR, there's no doubt about it. Liver is there. The icterus has come up, which has only come up because of the heart failure. So you have to think of something else in addition. Maybe the patient has PDA, but something else in addition. So can you think of something? What could be there in addition, at least theoretically?
Can you explain all these things with your findings, with your diagnosis? To try to explain with your diagnosis, then you bring other things.
So let us go. So we have discussed the clinical thing, that this
Another
is your
10 minutes.
thing. The patient is in heart failure, which we don't expect. And if the differential cyanosis, which they have proved by oximetry, then probably PDA is a possibility. But there should be something else, either some AV valve problem or some tricuspid valve, or primary tricuspid valve problem. Something has to be there in addition. I don't know. So we can go.
Yes, sir,
Madam,
investigation.
Dr. Anita, you want to say something or we move forward?
I want to first say, why have you written acyanotic congenital heart disease when you got cyanosis?
Well,
Initially, we can take.
No,
नहीं,
the
मैं
diagnosis
कुछ
is
कहूँ,
Final
इसमें
the diagnosis is current diagnosis. We are not
Current
talking about past diagnosis. Current diagnosis patient is, and there is nothing like Eisenmengerization. You know, he's a great man. Don't trivialize him, please. Eisenmenger was a great man. So please write.
you should say severe PAH. You say
Okay.
postductal PDA with severe PAH. That's it. Why
You
do
can say Eisenmenger syndrome. I don't mind. You should say
Okay.
actually,
Okay.
but not Eisenmengerization. Okay.
Okay.
Then the next thing is this severe TR, widespread second heart sound. Somehow you have to give an explanation for that. It is not going to go with the straightforward PDA. Congestive heart failure is very gross, as you have said yourself. I don't know why it is not featuring in your complete diagnosis. So that also must come. So now you have to keep a differential diagnosis. When you are stuck with these kind of things, then it is better to have another differential diagnosis. Do you have one?
And just one more thing, you could detect the patient is undernourished. Can I say this could be even cardiac cachexia?
Yes, sir,
You see,
because of failure.
So this is a cardiac cachexia rather than undernourished. Okay. Yeah, you answered the question which Madam asked.
Any DD, any differential diagnosis? Supposing I say that is primary PH, it just happened to have a small PDA.
Usually common in
You
female.
see,
Because he was quite fine till 13 years of age. His problem has started on 13 years of age and now he's deteriorating, right?
Yes, yes, ma'am.
So if I say that his PDA is incidental and it is small to moderate, not the cause for PH, but it is more like a primary PH, what is against it?
But differential.
Yes, I'm saying there is a PDA.
there
It is
has to be something
incidental.
in addition, we said. No?
But primary PH with a PDA, PDA is responsible for causing differential cyanosis, but his PDA is not large enough to cause Eisenmenger. So like, you know, you were being told about a small VSD where PA pressure becomes suprasystem.
See, I think they have been led away. They have been led away by that childhood history. And they are sitting, I don't know. Maybe there is
I think the childhood
That is-
history is also not very secure because initially she said up
that's
to
what I'm
10
saying.
years of age, then it became 3 years of age. I don't know whether it is the right history.
Tell
because
me what will be the RV pressure? Will it be systemic, suprasystemic in this patient? Tell me this. Seeing the clinical condition of heart failure, this patient would have a systemic RV pressure or suprasystemic or subsystemic. Answer this question.
Pressure.
What is theoretically possible?
Huh?
Theoretically, what is possible?
Severe TR with suprasystemic pressures possibilities.
So this patient will certainly have suprasystemic pressures. Otherwise, he will not go into this gross heart failure. And for that, you need an intact septum situation where the PDA has to be restricted. It has to be moderate, or as Madam said, I think this pressure, or there is something which is closing the V. Sometimes you get situations that there was a VSD, but
I think what is important for you to understand is that if you make a diagnosis where things are not fitting very well, please do think of some other possibility. I would agree with you. This is the first diagnosis. I'm not disagreeing with you. But point is that with this diagnosis, there are few atypical things. And therefore, as a clinician, you need to think of something different as well. And therefore, keep this as your first diagnosis. But do think of something else.
Ma'am, CTPH possible, ma'am?
Sorry?
CTPH, ma'am. Chronic
You don't have any history suggestive of pulmonary embolism. So I'm saying primary PH because I don't have any other history. So
The patient have any history of
no history of episodes.
It is also possible. It is also possible that the patient has a large ASD and a ASD PAH situation, and PDA is incidental.
no, but in that case, cyanosis should have been uniform.
Yeah, I know.
Differential is
No, but still, when it is reversing, it will also reverse through the PDA. So some differential may still go.
Generally, the proximal shunts decide. Generally, the proximal shunts decide. Proximal shunts decide the clinical picture, not the distal. So it's in all probability he should have had some cyanosis in the upper limb also. Maybe there will still be some reversal at PDA level, but some cyanosis should have shown. So that's hard. I don't think there is an ASD, but I would agree with your diagnosis. But there are two atypical cases, therefore you need to explain that, and therefore keep a differential diagnosis. Always keep a differential diagnosis. It can't be so dogmatic. Otherwise, the examiner will say, you know the diagnosis. Somebody has told you the diagnosis.
Did the patient have?
Okay, let us move forward. Let us go to the ECG X-ray.
Yes.
Okay. Let us go to ECG X-ray.
This is the chest X-ray.
Okay.
Chest X-ray PA view showing
What does it show?
Lateral rotation with cervical scoliosis and cardiomegaly with RV type of apex and prominent pulmonary artery with RA dilated.
So do you expect RA dilatation in PDA?
No, sir.
No, sir.
You don't expect?
Yes.
So this has to be either PPH or ASD PH or a pre-tricuspidal PH or
I think Dr. Goyal, I think we should give student a chance to read the X-ray properly. Let her read the X-ray, let her finish it, and then you can discuss.
Okay.
Chest X-ray PA view showing rotation to the left with cervical scoliosis and over penetration is there. Cardiomegaly is noted with RV type of apex and RA is dilated with prominent main pulmonary artery and pulmonary vasculature is peripheral pruning is there. And costophrenic, cardiophrenic angles are clear.
So when you have so much rotation, would you still think about RA enlargement?
But
you did percussion. You never found any RA enlargement on percussion. So could it be all because of rotation?
No rotation hai isme.
Rotation
How much rotation are you saying? This is a rotated film means? Because the two hemithoraxes are about the same size and the clavicles are almost at the edges of the clavicle on the left side is ending here on the spine. The right side is also on the spine. I don't think it is a rotated. It's pretty centered film, I would say. I don't think it's a rotated film.
What are the other signs of rotation? Is there any volume? Is there any volume loss on one side? Is there any crowding of ribs?
Hyperinflated things can be seen, sir, rotated.
Yeah, you have one side which will be smaller, the other will be
Other
bigger.
side will be
It will like a RAO or LAO as we see. So, but this is pretty symmetrical, I would say.
Which hemithorax is small?
side, left side.
Left is very small, no? Left
Yes,
is much smaller compared to right.
Right.
Now, but the left
Even-
dome is lower.
No, left hemithorax is small. If you look at the epices, definitely left is smaller. So there is obviously some amount of scoliosis that is changing the picture. But what I'm saying is that when you are interpreting an X-ray, you need to keep these things in mind. Look at the levels of both clavicle. One is lower, the other is
One
upper.
is, yes.
There is crowding of ribs on the left, upper ribs on the left side. So all those things might make RA look more prominent because on percussion you had no RA.
Yeah, yes, ma'am.
What is
But
that
anyhow,
prominent?
I strongly feel RA is very large. Anyhow, we'll see that.
No, likely to be, very likely to be, because
Yeah.
there is severe TR, but we need to know whether it is really this
And
large or
even by
little
X-ray,
less.
it looks.
Yeah, yeah. Sure.
What is a prominent structure on the left heart border which is bulging?
The dilated main pulmonary artery, sir.
Hmm.
And above that? Yeah.
This
What is
one, ma'am.
this?
Usually aorta will be there. Here,
Aorta is also a prominent.
from
So we have
Something in
crossed
between.
50 minutes. The time allotted is
No,
only
I
40
think we
minutes
should
per
move
candidate.
forward then. If it is
We'll go forward.
Let
Yeah.
us see the ECG and show us the echo, and then we'll see what is.
this is the 12 lead
Interpret the
ECG with
ECG.
normal standardization showing normal sinus rhythm and sinus tachycardia. With the RV axis is about 180 degree. Our right axis deviation is there with the RA peak P waves in V1, which is suggestive of RA enlargement, and R wave in V1 is more than 6 mm, so which is suggestive of RVH, and RS ratio is more than 1. And there is asymmetrical T wave inversions in V1, V2, suggestive of RV strain.
This
Okay,
ECG was done at your center. This ECG was done at your center.
Yes, sir. Yes, sir.
Actually, there is a mode in the ECG called auto gain control, automatic gain control. You know, you should not have QRSs running into each other.
Yes, sir. We have taken half standardization ECGs.
Yes, that is right. Okay. Okay.
This is the posterior coronary showing aorta is on the left side and IVC is on the right side. IVC is not, I is dilated and non-collapsing. Suggestive situs saltus.
Okay,
IVC dilated non-collapsing.
go ahead.
There is no hepatic flow. This is the subcostal four-chamber view showing dilated RA and RV with trivial mild TR with the septal bulge into the LV.
This is subcostal view.
Yes, ma'am. Yes, ma'am.
So what should you comment on specifically here?
KSD, there is no
Yes.
evidence. Yes,
Yes,
ma'am.
please talk about that. Then other
Yes,
things you can talk in other views also. Here, this is done for atrial septum.
Yes, yes. Ma'am.
Okay. Next.
This is parasternal long axis view showing dilated RB, ma'am, and no evidence of MR, and LVH is there, and there is no
LVH?
AR or AS.
Why do you say LVH?
Posterior. I mean, posterior wall is looking like thickened, sir. Based on measurement,
where?
I'll confirm.
No. There's no L. Why should it?
I don't think there is LVH here.
Why should there be LVH? And there is no LVH. It is normal size LV. This is actually the subvalvular apparatus. You have to see the endocardium behind, which is pretty normal endocardium and the myocardium. When it merges with the mitral valve apparatus, then you get a bigger thickness. So that is not how you pick it up.
Do we have an M-mode measurement?
Yes, sir. Yes, sir. Measurements we have, sir.
So best is not to get into trouble by telling LVH here unless you see the IVS thickness
Yes,
and
ma'am.
posterior wall thickness measured. Okay. Don't unnecessarily say something where the examiner will object to it.
Okay.
Hmm.
This is the apical four-chamber view showing dilated RA and RV with mild pericardial effusions.
Mhm. Okay, next.
This is the color compare, apical 4-chamber view. There is no flow across the IVS
Okay.
and
How
mild
much
TR
was
is.
the RV pressure? Did you get the TR jet velocity?
Yes, sir. Yes, sir.
Let's see the next. Okay, no,
Yeah,
no
this is-
VST. Okay,
no.
next. Next.
Mild
Yeah.
TR.
So your
How
TR
much?
is very little, you know. I don't even know whether you auscultated TR or something else, because this TR should not even produce grade 2 murmur.
How much was the TR velocity, you say, by the way?
71.
Hmm?
Gradient.
71. Okay. This is not a good
Right.
signal, therefore it's hard to say.
Ma'am,
Okay,
this
next.
is the alarm. We have exceeded 55
Ah.
minutes.
Chalo bhai,
His TAPC is
let
0.8,
us at
sir,
least know
suggestive
what
of
is
RV dysfunction, and this is
True pulmonary
short axis
artery.
view at the aortic wall level, suggestive of dilated pulmonary arteries, and
Go ahead.
there is
So could you see the PDA? Just tell us. You saw the PDA there?
yes,
On
sir,
echo?
yes, sir.
Yeah.
Dilated. Here, sir,
Hmm.
with bidirectional shunt.
Hmm.
This is the size of PDA, sir, 1.19 centimeter.
Hmm.
This is the
Can you
gradient
calculate
is
the pulmonary artery pressures from this Doppler?
Chalo, I think we'll have to move.
Yes. Next case, we have to go. We have
Yeah.
taken 1 hour. complete.
So I think the only odd thing in this was the CHF and such a big dilated RA and RV. I don't know if there is some. I can't explain that. I don't know if anyone can explain.
here
Usually
one
you
echo-
don't. Usually you don't get that much, if it is because it's clear cut.
But I'm surprised that we are not getting any or very little TR on echo. So I don't know, is there a TR murmur? I would be surprised. This TR seems very little. I mean, echo is quite compatible with PDA, PAH, Eisenmenger, but your clinical examination is not.
But
In clinical examination, we saw the pulses in the epigastrial region, the JVP raised with 2 waves. So I think there is a severe.
systolic
Maybe they
murmur
are
is
not
there,
picking
ma'am.
it up. Some other.
What will you do? What will you do for this patient? What is the management?
Medical, as the patient has already developed reversal of shunt, so we'll stabilize the patient by decongesting the patient, sir.
Okay. What specific
What
therapies will you
treatment?
give?
What specific treatment will you give? Just one word, one line, so that.
Phosphodiesterase inhibitors.
So you
And,
you will treat
ERS.
him.
Which is the one which is recommended among the specific pulmonary vasodilators?